Okay, everybody, sorry for just a little bit of a delay here. Dr. Broumand is literally in the process of logging in right now. But want to thank everybody for joining tonight's webinar with TRI dental implants, the only FDA-approved dental implant without an abutment in the world. And we have a special guest, which we're really excited to demonstrate some clinical slides with you all and some cases, is Dr. Vishy Broumand. For those of you who don't know Dr. Vishy Broumand, he's a world-renowned oral surgeon with over 20 years of expertise in major oral and maxillary reconstructive surgery. His exceptional skills in these specialized areas have earned him global recognition. Dr. Broumand's proficiency in zygomatic and pterygoid implant surgeries allows him to provide innovative solutions for complex cases, helping patients regain their oral health and function. In addition to his remarkable surgical abilities, Dr. Broumand is also a dedicated educator. He has shared his knowledge and expertise by teaching over 250 surgeons, dozens of general dentists, and passed on his skills in advancing the field of oral surgery. His commitment to teaching and mentoring ensures that future generations of surgeons are equipped with the necessary expertise to deliver excellent patient care. Just early on, me knowing Dr. Broumand also, I would call him a very early adopter. During my time at SprintRay, he was first to adopt 3D printing workflows into his oral surgery practice, certainly providing exceptional value for referral-based dentistry, and certainly a very good friend of mine. So we're really delighted to see his skill sets and some of the cases demonstrated on the TRI implant system. Before Dr. Broumand logs on, I'm just going to give a 15-minute overview of the value proposition of who we are, what we do, what we do things differently in implant dentistry today, and then I'll be turning it over to Dr. Broumand. So thank you once again for taking the time. My name is Christopher Luter. I'm the current president of the United States business for TRI. 20 years now in the dental implant business, 10 years pioneering the All-on-X technique early on with Noble Biocare. I was one of the key executives to launch and build the brand Neodent for a 6-year run. Spent 3 years with SprintRay and 3D printing as their vice president in sales, and now exactly 1 year with TRI, and really exciting times to see how we're doing things very differently. There's Dr. Broumand just logging on, and you missed the introduction, my friend, but we're all excited to hear you, and certainly hear you first, and me certainly second. So just a quick little overview of TRI. We're not a new implant company. We've been around now year 12, heading in 2025. We are based in Switzerland, and the Matrix implant, which we'll be talking about today, has now been inception, also going on year 5 globally. We're in 49 countries. We're the fastest growing dental implant system in the world, and we're really excited to do things certainly without abutments and the complications they provide. Our CEO is Tobias Richer. He comes from also a very disruptive implant background, having spent many years with Straumann, launching Implant Direct side by side with Jerry Nisnik, selling it at the same time, and then 11 years ago starting the company TRI. So everything we do is high performance with the most quality in implant dentistry, having manufactured and innovation coming from Switzerland. Everything we do is digital, and digitalization is certainly the future of the way cases are planned and treated today in implant dentistry. And as you can see, hopefully throughout this presentation, we'll see this implant is extremely simple to work in your practice, reducing components, reducing cost, and certainly inserting our prosthetics, all screw retained into the implants. So we know what abutments do today. They solve a lot of things we do in all our implant systems. We know obviously the primary indicator of what abutments do is they correct our implant angulations so we can achieve necessary prosthetic outcomes for patients. We also know that they carry the mechanical load of that force in between. So we know that confidently we can speak that our single unit restorations are not going to break over time, and certainly our full arches and our bridges. They carry that mechanical load so those complications don't take place. We know obviously a lot of these All-on-X cases, working at the multi-unit abutment level up is certainly a lot easier because we can see everything and certainly restore those cases from abutment level up. However, they do come with complications. We know that single unit titanium base restorations, they can become at times debonding from crowns. And that certainly isn't good. That leads to more patient visits and certainly higher costs to redo those cases. We know that custom abutments, so titanium custom abutments, those are cement retained restorations. And we know certainly through time that cement does cause implant complications and implant failure. We see a lot of it from a design standpoint now that a lot of these all-in-X cases are going digital, and we do see quite frequently incorrect usage of multi-unit abutments, whether it's a wrong height, whether it's a wrong angle, and that does cause complications down the road for a lot of these all-in-X cases. Certainly, we need to leave room for multi-units, and when leaving room, obviously, there comes time where you need to reduce more bone. So if we can eliminate multi-unit abutments, that's certainly better for patients that we don't need to, we can have less bone reduction. We also see with these digital arches that Rosen screws or desk screws or Powerball screws, a version of a PRH screw, those tend to sometimes come loose. And those also come with complications as well. Also, added inventory from having straights, 17 degree, 30 degree, 45 degree, all the different vary heights, that causes inventory in a clinic. And certainly we know implant dentistry is not getting less expensive, it's increasing. So we can reduce that cost. I hope we can agree that's a really good thing for treating more patients and remaining profitable. So I touched base on this that, we see sometimes when a patient gets a full mouth reconstruction, what do? They lift their lip up. In a lot of cases, even to this day, we see on Instagram and Facebook, we do see multi-units. So if we can avoid that, I think we would agree this is a better aesthetic outcome. The center picture here shows just a traditional titanium base that's debonded from a crown or bridge. And we already talked about that. So this implant is certainly one of a kind. It's groundbreaking innovation that allows us to now 3D print or mill directly to the interface, avoiding multi-units, avoiding tie-based restorations, cement retained restorations. And this is all possible because of this bolt screw that I'll be talking about in a little bit. It's 2.8 millimeters thick. It's essentially double the thickness of the screw you guys worked with today. It engages very deep in the implant. And this is one of the key features that carries the mechanical load so our bridges, our crowns, and our arches are actually stronger than abutment level restorations and carry that mechanical force. This is just a quick snapshot from an indexed single unit crown so we can see the connection. A lot of feedback that I receive is, oh my gosh, Chris, this is a tri-lobe connection. This is not a good implant. We know tri-lobe connections are flat on flat connection. We know that is a common indicator for crestal bone loss. And we know that implants have innovated to go to conical based implants. And we know that conical implants limit bone loss. And I would say is the gold standard for implants today. So key to note, this is a 20-degree beveled conical connection implant that is indexed for our crown. And this is essentially a timed engaging restoration. And we reverse engineer the interface, as you can see here. And this interface here that locks one of three ways is just a seating mechanism where the force load that I will show you in the next slide is not compromised. So you get the benefits of no abutment and a zero bone loss concept type implant because there is no micro movement having no abutment and a locking feature with our bolt screw. And this next slide here shows exactly what I'm talking about here with our power base, bolt screw with polished zirconia on titanium for incredible aesthetic outcomes. And we can see here the compressed forces are all on the screw down to the implant and not on the restoration. So the key to note here is we are the only fully digital implant in the world. And by this offering, we have a lot of great value propositions of what we call our integrated apps that help streamline your practice. So I'll be quickly touching on our Scan and Smile in 1 hour, our digital healing collar library for posterior single unit restorations, as well as all on X cases. We'll be talking about photogrammetry and an alternative to photogrammetry, which is our ScanBridge. And last but not least, we'll be touching on the tooth in a box and arch in the box, and certainly our design capabilities from our lab design, and also having an integrated milling. If anybody has an in-office mill in your practice, we can certainly take care of that and onboard your mill. Everything is an open system. So as I mentioned, we'll first touch on the Scan and Smile in 1 hour. We know that in the aesthetic zone, so maybe I'm talking about tooth number 7, we have 4 different workflows on how to temporize that patient. We know in your current implant system, an option is to let the patient place an implant and have the patient leave with a flipper or an Essex template. Or third, most likely we're provisionalizing with a temporary abutment. We have a shell. We're flowing Luxatemp to that shell. We're light curing it. We're bonding it. We're staining and glazing it. And the patient leaves with a screw retained temporary abutment tooth out of occlusion. All 3 of those workflows in the aesthetic zone, we can do that today with the TRI system. So we actually have temporary abutments if you did not want a 3D printed restoration. However, option 4 is to place an implant, insert a scan body, and within 20 minutes, you get an STL design back formatted to send to your 3D printer for a cost of $20, a design fee. You would send that design right to your 3D printer, and for roughly a cost of $10, would be able to 3D print a tooth in 20 minutes, characterize it, stain and glaze it, and leave that perfectly designed tooth out of occlusion, and a patient leaves with a perfect design. So we're going to show you a case on here of what this means and how this can also eliminate a patient's visit. So here we go. This is just a nice case from my good friend, Dr. Ryan Dunlop. This was his Scan and Smile in 1 hour with one of his, actually his father-in-law. An implant was placed here, as we can see, extracted tooth. An implant was placed surgically here with a TRI matrix implant. We see that we got incredible insertional torque with the implant. A scan body was inserted directly to the implant. A design was done in less than 20 minutes. It was sent to a 3D printer, and all with under 1 hour here, the patient left with this perfectly designed tooth. The beauty of this is the fact that the tissue response is absolutely perfect the way the patient's natural anatomy should be. And the same exact design was used so that the next patient visit, the tooth was fabricated, ready to go. The provisional was removed. And then the very next, within a matter of minutes, inserted a zirconia restoration right to the interface. And we can see here just incredible results, all restored within a matter of minutes. No titanium base, no cement. A screw axis hole based on the design of an angulated screw was used, torqued to 35 Newton centimeters. And this patient was restored again in a matter of minutes in the office, eliminating much confusion for the staff members, and certainly abutments were eliminated in this case. I believe this is a case that each and every one of you should be able to do in your clinic today. If you did not have a 3D printer, we'll talk about that at the end of this presentation, how we overnight you a 3D printed tooth, so you can deliver a customized solution if you did not have a 3D printer. Next on the list here, I'll kind of fly by this rather quick here, is our digital healing collar library, which is an amazing advantage that, at least from my IQ, there's no other implant system out there that has this option. This is an STL file that we provide you. It is designed for all your anatomy of your teeth, from premolars to anterior cases to molars. These are all white like they should be. And if you did not have a 3D printer, we can send these to you at no charge. But this is the way this case should look like. You can also characterize these and stain and glaze this. Coming from the implant world of almost 2 decades, I find it a little archaic that metal healing abutments are used off the shelf. The soft tissue certainly does not look like this when you use an off-the-shelf metal healing abutment. And most important, if a patient opens their mouth, you see white, or you can certainly see, you could glaze this in a matter of minutes here, and you see a tooth in place, essentially. So this is a nice value proposition we provide you, and also have these for your all-in-X cases during the design phase, so tissue doesn't collapse. So we know we're here for certainly for all-in-X, and Dr. Broumand will be showing his all-in-X cases with the matrix system. But this video kind of shows it all of how we can angle our dental implants right to the interface. And most importantly, the angulated screw channel, which really makes this implant possible. The fact that we can angle these up to 30 degrees so we don't have screw access holes coming out the facial. So we know this implant certainly is now possible due to intraoral scanners, due to photogrammetry in the market, due to inventions like the OptiSplint or our ScanBridge, and certainly mills now are more accurate, where they can mill unbelievable divergences, coupled with the angulated screw channel, now make this implant possible, where maybe 5 to 10 years ago it couldn't be possible due to the technology advances. So now we can predictably avoid multi-units. We don't have to reduce as much patient's bone. We can eliminate these vortex and Powerball screws that come loose, and certainly simplify this treatment plan and mill zirconia right to the interface of implants, which is a significant advantage. For those of you that maybe have a photogrammetry unit, don't worry. We're certainly big advocates of photogrammetry. You'll be seeing a ScanBridge case. You'll be seeing an iCam case from Dr. Broumand. But we are all compatible with all the systems, from MicroMapper to Tuple to the iCam to PIC Dental. We have the scan bodies that go, instead of a multi-unit, they go right to the interface. And we also have adapter as well that you can use that goes right to the implant. You can use your same exact scan bodies you have in your clinic today with no additional investment. If you didn't have photogrammetry and you maybe do less than 5 arches a month, we certainly think this is a fantastic alternative, which is our STL file printed ScanBridge. I like to think these are extra small, small, medium, large, extra large. Based on your AP spread, these click in seamlessly to the chamber of your scan bodies. That allows a traditional intraoral scanner to get a single scan versus a dual scan and capture the positioning of your implants to get to the design stage. And I'm sure maybe some of you will have some questions for that. Feel free to ask questions after this, and either myself or Dr. Broumand will certainly answer those for you, but you will see a case here shortly. This shows from a Trios 5, scanning on the ScanBridge roughly in 90 seconds. That obviously gets you to an accurate scan to get to the design stage to then send for a printed provisional. Once again, if you do not have a 3D printer, we have a service where we provide you the all-on-X Sprint Ray on-X tough resin, designed and printed right to your door by 10:30 a.m. the next day, so you can deliver the patient's teeth. So just due to time, starting late, I'll skip this, but you guys can understand what's being done here. This is important to know. This was a live study. Many of you may say, how is this absolutely possible? I'm so worried about my bridges or my crowns breaking. We're going to place a single unit crown right to the implant on a 30-degree angle, non-splinted, and have a strength test that's double the amount of human that any person could bite down.
We have a 2.8 zirconia screw.
This gentleman here going over, his name is Holger Kass. He developed the Straumann bone level implant. His name is on the patent, and his name is also one of the key engineers to develop this implant.
On this ground, I'm going to add as much weight as least as we tested it in our official test. So that's the first 1.25 kilo. 7.5. This is the next 2.5 kilos, 25 kilos. Right now, we have 80 kilos, the maximum of any human can bite. So how is your bet? What do you think? How much more? 100 more? 150 kilos on one single crown, 165 kilos. Okay, to finish that, I will add all the kilos on it. 177, that's enough. Woo! I think that's amazing.
So again, we have dozens of independent studies from universities, clinicians, validating roughly 4 to 5 years now we have of studies of longevity of these implants. We have also studies of 1 billion chewing cycles that are simulated with all different kinds of materials. And we see just incredible results of little to no wear from zirconia to our titanium, and certainly no breakages taking place. Also key to note, as I mentioned, we are, since we are a fully digital company, we are also a design company, and we are also a milling company as well. We like to say we have the best offering root to tooth in the dental implant business in the United States. We offer a full arch design in 1 hour for $250. We offer a single tooth design for $20 in 20 minutes. They're very easily to schedule on our www.tri.swiss. You go to design or milling on the top right-hand corner, and you can schedule these as long as you're 48 hours in advance. We're on demand. We're waiting for you, ready to design your cases. When it comes time to ready for phase 2 and certainly get ready to restore these cases, we also offer finished and unfinished prosthetics right to your door or right to your laboratory. So for as little as $600, we mill you out a milled and centered zirconia full arch restoration. If you would like it to be completed right to your door, we offer a very high aesthetic all-on-X case for $990, including design, right to your door in 5 days. And if I like to say, if you wanted the Rolls Royce or the Beverly Hills 90210 patient, a very high aesthetic finish for $1,500. For the single unit restorations, $60 unfinished. For as little as $110, $160, $180, good, better, best, you get a crown right to your door. Again, as I also mentioned, we offer some additional services such as all-on-X hybrids. If you didn't have a 3D printer or your 3D printer broke, or if you need another alternative, we have you covered there for $375, including shipping, includes the design, and you have your all-on-X teeth the next day ready to deliver to your patients. Hopefully everyone agrees this is highly disruptive, and we're really excited about this full root tooth offering with our implant system. Many of you may say, oh my gosh, this is great that we're eliminating abutments. However, I still want to remain profitable in my practice and still be able to bill out for that. Well, we also have you covered there as well because of the reverse engineering, that interface and that seating that fits seamlessly into the implant. That does check the box for insurance carriers. We have this validated by very large DSOs, and it has been working for years seamlessly with no issues and no problems in your practice. And again, it is validated. So you're still having that benefit of that abutment implant crown. Many of you may ask, what it takes to get in our system. For as little as $6,875, we have a great starter package that comes with 25 implants. It comes with a complete tooling setup. You have everything you need, from scan bodies to additional tools, to your surgical kits, to the final screws. You have everything to get rolling, and we also have an additional incentive as well for you. If you needed a 3D printer, we're a dealer of Sprint Rays. And this is also an incredible value where you buy 100 of our implants. You get a full ecosystem. We have clinical doctors on staff as well that come to your practice, that train you, train your team, that comes at no additional cost for you. Maybe if there is some advanced surgical procedures or even some additional digital technology needs to be figured out, we have digital consultation doctors on staff that will take care of you and make sure your workflow is impeccable. So not only I like to say we're a dental implant company, but we're also a consulting company that comes right to your door. I like to also say this is the Vish special. If one of those starter packages makes sense for you, which you hope it does, we're giving away a free zirconia arch for you, or 5 free zirconia implant crowns at no additional cost as part of your package. It can also, your arch can be redeemed if you have a Neodent or an Implant Direct or a Straumann arch sitting out there and you need to get that restored. We can take care of that for you as well at that price. And you could use your voucher to cash that in. We offer 12 months, 0% financing. That arch alone covers, I would say, you know, on an average cost of $3,000, that covers that cost for you as well. If you looked in to get that 3D printer, we throw in this NanoCure and we throw in an arch kit. That arch kit speeds up your prints for 20 minutes where you deliver that. And hope that 3D printing, I think, is definitely here to stay. It's I like to say it's a standard of care. And I think every dental practice should have a 3D printer in practice because it does so much for you. Outside of just the All-on-X hybrids and crowns, it can do night guards. It can do surgical guides. It can do digital dentures. It's just a fantastic tool to have for your practice. Thank you very much. Again, I'm Christopher Luter, the president of TRI USA. Here is my cell phone if anybody needs to get in touch with me. If you're on Instagram, feel free to friend me. It's LUTTER 2323. And now I will pass it over to my good friend, Dr. Vishy Broumand. Excited to see your cases, my friend. Dr. Broumand, the stage is yours. There we go.
Can everyone hear me? Chris, there's a couple of questions from the audience, if you can answer them. I was just getting ready to, but if you can. Good afternoon, everyone. Thank you for being here. I'm going to share my screen with everyone so you can see it.
I'll certainly get to those questions right after the webinar. I saw one of them and I went away, but I will definitely get to those questions.
All right, give me 1 second to go to the very beginning of my lecture. All right, perfect. Can everyone see my screen? I hope so. Thank you again for the great lecture and great presentation, Chris. It was great. As Chris mentioned, I'm Vishy Broumand. I'm an oral surgeon here in Phoenix, Arizona. I've been working with TRI for close to a year now, and I can't say enough good things about the system. This is my practice, Desert Ridge Oral Surgery Institute, and if you have any questions, I'm actually very readily accessible on Instagram. You can scan that, and I'm happy to answer any questions. So let's talk about TRI matrix, right? So what separates this system from everything else? Well, if you look at the old world, you have all these different kinds of abutments. And in my practice, you know, I started out doing full arch with Straumann tissue level, and then the 3i old osteotites, and then, you know, I just moved along Nobel trilobes, Nobel parallel, so many different systems. So you see them all here, the ones that I've used in the past, and sometimes we still have indications to use them, but there's nothing worse than when a patient comes in and has had a full arch done years ago and something breaks and you can't find the parts and pieces for it because either the company's no longer there or the parts and pieces, they've moved on to newer implants, and you're not able to use the system anymore. So you have to have a lab custom make them for you. So then comes the new world. Now we have scanners, we have 3D printing, photogrammetry, and so many other new techniques that are available to us. In my full arch practice, I've moved away from the old world towards the new world. So there's a mismatch for lots of us. So that's what's great about TRI, is it offers so many new things for full arch, and of course singles and bridges, anything you do in your practice. For me, in my practice, it's mostly full arch. What's great about the system is if I'm still doing singles, I can use the tissue level implants. I still like using those at times, but for my full arch, I'm using the multi-level implants, and I'll show you some examples of some cases of what to do and what not to do in some of these cases. So of course you have the bone level and you have the multi-level implants, or you can use them for tissue level. For most of my cases, I'm actually using the multi-level implants because in some cases I have, in the same patient, I have areas where it's indicated to use a bone level implant or a tissue level implant. So I mostly the 3.7 tissue level or multi-level for my full arch cases, and you're going to see some cases here, but they're both great implants. This is what the inside looks like, as Chris was showing. Everything locks in place securely. So whether you're using the tissue or multi-level, it's multiple platforms, but one implant body. So that's what's great about this implant system. Same kit for drilling and placement of the implants is being used, and you don't have to resort to using multiple implant surgical kits. So this is perfect for the aesthetic zone, obviously in the anterior regions. That's what I prefer to use now for my singles and implants in the aesthetic zone, especially with a very thin biotype, where I don't want to have abutments show through my thin tissue biotype. So how do we place these implants? So if you're using the multi-level implant, you can place it above the tissue level. You can place it at the bone level or slightly above. With the bone level, you can place it at the bone. What you don't want to do is place it subcrestal, because then it becomes difficult to restore. Although I have placed these successfully subcrestal and restored them without a problem, and I'll show you a case where I did that. So even though we don't recommend placing these implants subcrestally, if you do so, you're not doomed. And I'll show you a couple of cases where we did that. So this is ideally, you don't want to place the implant subcrestal, but it can be done. What's great with the matrix is obviously you're going to have less crestal bone loss because there's no abutment, there's no micro leakage, and that's one of the things that haunts us. You know, people jump around from implant system to system. I did it myself back in the day, from 3i to Nobel to Strawman to Zimmer and to Astra, and you know, crestal bone loss is something that haunts us. You know, we went from the hex connection to conical connection. Well, it's always the abutment, which is the missing link or the weak link here. So when we're using these implants, long-term follow-up, you see no crestal bone loss. This has been fantastic. So the results are fantastic, and they're there to stay. There's a lot less components, right? So one of the biggest expenses when we're doing full arch is the abutments. The multi-unit abutments can be quite costly when we're doing our full arch surgery. Obviously, even with crown and bridge, that can be an issue. Significant cost decrease when you're using TRI implants. So no abutment, no cement, and really no limits. So you can angulate these up to 30 degrees easily. As far as materials go, you can use PMMA, you can use metals, you can use zirconia, you can use it for single crowns, bridges, full arches, which is the bulk of my practice. You know, I have not had to resort to a divergence of 50 degrees, but really, technically, you can really go even more, and you don't have a limitation with screw channel access either. Easily up to 30 degree divergence and angulation. So in the areas where you need some angle correction, you're easily able to do it with the implant or with the screw access hole. So let's look at a couple of cases together. So this is a patient that comes to me with terminal dentition. Very difficult case, was referred from another oral surgeon. The patient flew in from Ohio because they told her that she was not a candidate for a full arch. Because if you can see here with the retractors in her mouth on the left side, due to some chemical and radiation burns as a child, actually, she had what we call microstomia. So she was unable to open her mouth and get implants placed at multiple offices. So she came to me for the zygoma because the bone quality was quite poor. For the maxilla bone quality was quite poor. So here you see that we did some zygomatic implants on her. I did some transnasals. The surgeon that originally referred it to me had recommended doing quad zygomas, but I felt like it wasn't necessary. Unfortunately, I see a lot of patients that are being overtreated in this day and age. I started placing the zygomatic implants 20 years ago when it was not popular, and now it's quite popular. But in this case, you know, we placed Neodent zygomatic implants because TRI is not making them yet, but that'll be something coming down the road where we can have transnasals and pterygoids and zygomatic implants made by TRI and no abutments needed. One of the biggest challenges with zygomatic implants actually happens to be when patients that with parafunctional habits break abutment screws and you have to get them out. And of course, the abutment connection is subgingival and you have to take it out. So it's kind of difficult. And you can see here in the mandible, we use TRI implants because she couldn't even open. So it would have been impossible to put a 30-degree MUA on there. It was quite challenging nonetheless, but we were able to do this, personalized her treatment, and she is quite pleased with what she got. You can see there's the temp in place, and we got a great result utilizing the TRI implants here in the mandible. This was her maxilla. We did a full digital workflow. I've been digital for the last 5 years. What's great about TRI is you can use it with the PIC, the iCam, or the micron mapper pretty soon. I know right now with the micron mapper you can't. There's some issues with the scan bodies, but that'll be within a couple of months.
We actually do have the micro mapper now, so we're good.
We do now. Okay, perfect.
Yes.
Because
Yeah,
it's
we've
not
been good about 2 months. Sorry, Vishy, to
no,
interrupt
it's okay, because it wasn't available to me recently, not long ago when I purchased my micron mapper. Flags were not available to me, so that's good to know.
Yep.
That we can now do that. So I need to order some micron mapper flags that are compatible with my.
Actually, I would just get you the adapters now. So I would just give you an adapter that you put right on top of your matrix implant, and you'd use your exact same scan bodies you have today, which is fantastic.
I see.
Everything
Yeah, so I have
same.
currently I had the ones for the PIC and the iCam, which have worked quite great. Yeah, I knew that you had to use an adapter for the mapper. So I know there's an adapter that you have to use. So, but this is a case where I did the zygomatic implants, the transnasals, and we'd have our palatal marker and the mandible, because obviously we weren't able to use any kind of photogrammetry here. We have the matrix scan bodies, and you'll see we connect them, take a very accurate impression. This turned out to be a perfect case. This patient was quite pleased, and it was worth the trip for her. This is the rendering that was sent after we do our iOS scan. For a different case, we sent it to the lab. And Chris and them were telling you, Chris has a fantastic lab where they're able to make a monolithic multi-layered zirconia restoration for a case like this for about what, $1,000? Is that what it is, Chris?
That is correct, $1,000.
Yeah. So this patient is still in temps. She's out west and quite happy with her temps. We 3D printed the temps the same day. I used a Sprint Ray Onyx Tough 2, and we've had very, very little issues with it at all. But in this case, you can see here we got our impression, and this is our temps being delivered on a model. And this is our patient now 3 to 4 months later. We got a new set of temps on her, and she's quite pleased. You can see here it's hard for her to open very wide, and we can barely fit those retractors in there to get to photo. But this is a tough case, and we're able to do this case with the help of TRI implants. So obviously, it allowed me to treat a patient that I normally couldn't have treated, especially for the mandible. And this is her with her smile. She's quite pleased with the results after 4 months now. Hopefully going to finals in the next few months. She lives out west. So you can see here that we were able to make a huge difference in this patient's life. This is the finals that they made for her. I know that they haven't delivered them yet. We just shipped them out because we used our lab out here, and the patient's living out in Ohio. So she'll get these, and I'm hoping to see photos of the finals. But like I mentioned, what's great here is you saw that we did a conventional all-on-X in a mandible. So instead of putting on a 30-degree multi-unit abutment, we just had divergence of 30 degrees in the back for the back implant. We didn't place any of these implants subcrestal, but I'm going to show you the next case where we did place the implant subcrestal. You have to use the correct scan body for these implants, so keep that in mind. I prefer the Trios intraoral scanner. In my hands, it works the best for all my full arch, because when there's any blood in the field, there's no issues. In the past, I used other intraoral scanners, and we had some issues with those. And we use 35 Newton centimeter for our final restorations. I put all my temps in 15 Newton centimeters. I have not had an issue with any of these screws fracturing, but obviously with smaller screws, when you're using any of the screws, it doesn't matter what brand you're using, Des, Rosen, Vortex, Jeffrey Tabone screw, any of them, they can fracture. This screw is a 2.8 millimeter. It's a pretty big bolt screw, and I have not had an issue with any of these fracturing yet, and they have their own the TRI screwdriver. So what's great not to have any models, no analogs, no tie bases, and no having to cement anything anymore. So obviously what's great is my local lab can manufacture these, but obviously you can get a lot of savings if you work with the TRI lab because of the cost is significantly less. One of my favorite things about this system is the screw. I love the size of the screw. It won't break. As many zygomatic implant cases that I do, one of the biggest challenges is fracturing of temps because of patients' parafunctional habits. Even the cases where I place pterygoid implants in, sometimes these patients, because of their parafunctional habits, will have screw fractures. So that's what I'm looking forward to. I've spoken with Tobias about this too, and Chris, about having a zygomatic implant down the road. So as I mentioned, the matrix is great. You already saw this video. I'm not going to bore you with this video again. I love every aspect of this implant, how everything locks in. And I'm hoping that we can do this with the zygomatic implants to counteract any heavy chewing forces. Most of my full arch patients have parafunctional habits. Oftentimes, I treat them with Botox to counteract the compressive stress, the tensile stress that comes on their implants. And that's why when you're doing full arch, I believe in immediate cross arch stabilization. That's what we've always done. So in my hands, the matrix has had significantly great results. I don't have to worry about tie bases coming loose after a couple of years because that's not an issue anymore. But remember, the matrix and the tie base, they have similar stability values. It's just a matrix is more appropriate, I think, for clinical use with all zirconia materials. And it's just as strong as an abutment. This is another case I'm going to show you here where I placed the implant slightly subcrestal. So this is a NHL hockey player. This gentleman played for a team where they won the Stanley Cup several years ago. And in all the years of playing hockey, you can see he looks like a hockey player. Got his maxillary teeth knocked out, broke his jaw with a hockey puck. They fixed him. Unfortunately, the surgeon who fixed his mandible put those screws to fix the mandible inside the roots of the mandibular teeth. So his teeth became quite symptomatic, but you cannot do root canals on teeth that have holes in them like that. So those teeth had to be removed. But he's a spokesperson for a company, and he was unwilling to go without teeth. This is a case where my friend Ryan Dunlop treated the maxilla and recommended the patient come see me for the mandible. So you can see here he used the scan bodies in the maxilla, made a beautiful temp. In my computer is showing it as pink, but it's not pink. They're nice and white teeth. But he did a great job creating a provisional, delivering this case for the maxilla. Patient came to me for the mandible, so I removed the plate in the mandible. Of course, I have the ICAM. In the ICAM, we have the flags to utilize with the TRI implants. That way, with the use of photogrammetry, I was able to place the middle implant somewhat subcrestal, actually quite a bit, because after we removed the screws and one of the plates, we found that there was a massive defect. But nonetheless, I wanted to place 3 implants because just in case we lost one, I wanted to have the advent of having at least 2 implants. We removed the plate, clean out the infected area. It was actually found to be just infection within the teeth from the screws that had come loose. So we placed the implants, bone grafted the area with membrane PRF, and then we utilized our photogrammetry, sent the result of the photogrammetry STL files to the lab with the intraoral scan, and the lab made me a temp. Obviously, it's a little bit long on the middle tooth. And we delivered a very functional, aesthetic temporary for this patient. He's been in these temps for quite some time. I'm waiting for Dr. Dunlop to send me some photos for the final. So you can see here that we placed an implant quite subcrestal. Chris, what do you think about that?
Yes, very subcrestal, and obviously a fantastic prosthetic outcome too.
Yeah, so I think that in this case, it would have been tough to do this any other way, but with photogrammetry, we were able to give this patient what he wanted, immediate results. We could have just done a bridge there, but after discussing the case with Dr. Dunlop, we decided to go with the 3 implants just in case we lost one, because those screws in the bone were quite deep, and we thought there might be a chance we could lose an implant. So once again, we got a fantastic result utilizing the TRI implants, and of course the ScanBridge in the maxilla, but in the mandible we did the photogrammetry. As I mentioned, my intraoral scanner of choice for full arch has always been the 3 shape. It used to be other scanners, but with blood in the field, I found that it was difficult. So I've gone all digital. This is my friend Adrian, the founder of Pick Dental. And when I first started using photogrammetry, I questioned them about other systems where we could use an intraoral scanner without the previous, generation of scan bodies. Now, with the matrix, it's very different. But you can see here that there's so much inaccuracies as you go across the arch if you're using just any kind of scan body. But with Trios, and of course with the TRI scan bridges, you don't get that. I mean, we get an amazing passive fit. So if you connect the scan bodies with a solid structure, then you don't have any stitching mistakes, because that's always been the problem in the past with full arch when you're using other scan body systems. Everyone's claim to fame is that they have scan bodies that work quite well, but with the scan bridges from TRI, they actually work well because I've used them with quite a degree of success. So we have had no stitching errors. Now, one of the things that I've noticed that when I lecture all across the world is that a lot of the countries, even without the use of photogrammetry, they are very, very much facially driven. So this is what the scan bridges look like. You put the scan bodies inside the implants, and you connect them with the scan body, and then you put some composite to stabilize them, and you do an IOS scan, just like Chris was showing. Some people even take an impression of that and scan that impression. So it works quite well for even if you don't have photogrammetry. So this is how we did it for our patient here in the mandible. Because remember, I did not have photogrammetry for this case from the very first case that I showed you. So if you're using the scan bridges, you're basically going to scan, send it to the lab, print it, and deliver right there in your office. I have the Sprint Ray printers. I love them, and they've been fantastic for me. It works really well in my practice. So that's what I would recommend. And like Chris said, if you don't have 3D printers, then they can overnight them to you. But almost everyone has multiple 3D printers now in their practice. So one of the things that I noticed when I was lecturing in Italy earlier this summer is everyone questioned as to why we weren't facially driven. So in the last year, I purchased a facial scanner from my friend Art Morellis at Instarisa, and I've become more and more 3D driven. So instead of using photographs for a lot of our pre-op records, we use 3D facial scans to get our smile design, prosthetic design, and then we surgically execute this. So there's a patient that comes in, so 2D photogrammetry versus 3D facial scan. So you could use any facial scanner you want, but I think you get a much better smile design when you become driven by facial scanning. So not only do I have an intraoral scanner, photogrammetry, all different forms, but I also use a facial scanner in my practice to do my smile design. And it's great for patient education. So if any of you guys are thinking about taking a digital route, I think it's great to incorporate all these avenues into your practice. And this is a case, some records from my friend Keith Klaus, who's also recently wrote a chapter for me in my book on facial scanning. Him and Art Morellis, the two of them, co-authored a great chapter on intraoral records and intraoral facial scans to become driven, aesthetically driven using prosthetic records and facial scans. So Keith did a great job here in the mandible maxilla here for this case. So that's what I would recommend doing for most of your cases. If you're using the TRI system, either with or without photogrammetry, I've become more facially driven for a more complete outcome for my cases. So the key is to be digital. And remember, this is one of the first digital implants out there. So if you digitize your records, imagine no more conversions, no more verification jigs. The implant impressions are at the time of surgery. Your bite registrations are at the time of surgery. No more wax try-ins, no more bar try-ins. Your photogrammetry is your verification jig. And if you don't have photogrammetry, then you're going to have the matrix. No more face bows, no more off-center midlines, no more canted smiles, no more grinding in the occlusion because the occlusion is almost spot on every time. And no more creating smiles using 2D photos. You have 3D facial scans. And of course, one of the biggest advantages of the TRI system is tremendous less costs per case, whether you're doing singles, bridges, or a full arch. So for me, my digital dentistry workflow is I call it my phase 0. I acquire records. We send it all to the lab. So no more impressions. We do IO scans. We send our CT, face scans, and they create my smile design. I use ExoCAD, but if you're using 3Shape software or Zircon's on, they can do that for you too. Then we send everything to the lab. They create our smile, send it back, and we 3D print our attempts in the office. I don't do any finals. We send it to the lab for milling. So it's great. So like I said, this implant has afforded me to become even more complete as a full arch surgeon. And it's great if you're doing FB1 cases. I'm creating more and more FB1 smiles in some of my cases. And if you follow us on Instagram, you can see more and more of our cases that we're doing. And actually, I would recommend everyone start their digital journey today. This is our Instagram. If any of you guys are free in December, I would recommend coming to the Dental Implant Conference in Chicago. This year, the AAOMS, the American Association of Oral and Maxillofacial Surgeon Dental Implant Conference, is going to have a number of amazing speakers, including myself, Dr. Bacale, myself, Michael Malaro, Ramon Gomez-Meda, Alessandro Pozzi, Homlei Wang, Joseph Kahn, and a bunch of other amazing restorative doctors, Eric Baker. There's a lot of surgeons who do their own restorations there that are going to be speaking here. And I have 2 sessions. I'm doing a digital dentistry workflow with photogrammetry, 3D printing. And I'm also doing a lecture on full arch failure. Is there a role for traditional implants, non-traditional implants like zygomatic, pterygoids, and subperiosteal? Some of you may know I designed my own zygomatic and subperiosteal implants, and we've been having great success with them for the failing full arch or extremely atrophic mandibles and maxillas. That's my email. I'm always quick to answer email or Photogram, or our Instagram is Broumand Oral Surgery. And I think with that, we're open to any questions. I want to thank everyone for their time. Hopefully I'll see some of you guys in Chicago or at the next TRI meeting. But thank you again. If there's any questions, I think Chris and I are happy to entertain them now.
Yeah, excellent. I know there's one outstanding here by looks like Dr. Kalemi. Will it work with Shining Elite Photogrammetry? I know I've seen certainly a lot of chatter with that on a lot of social media. I have not got my hands on that yet. I'm certainly love to see that, and I don't have an update for you if it works with that or not. So I need to do my homework to make sure everything syncs properly. So great question, and I will certainly get back to you on that. We have another anonymous attendee that says, "Hi, maybe this is for you, Dr. Broumand. What is the limitation of matrix implant? Which cases are not suitable to be used? An example of cases simultaneously with implant and GBR."
Yeah, so actually that's a great question. I know if you look at some of the cases that are being done by like Dr. Gomez-Meda or Pozzi or some of the guys that do a lot of FB1, they're doing these cases very successfully and they have no limitations there. The only limitation in my practice is when I'm doing the extremely atrophic maxilla because I need long implants to do zygomatic or pterygoid implants. And I know they're going to be making longer implants soon. So then that limitation becomes no longer a limitation. It won't be a limitation. I think the only limitation will be when you're trying to place zygomatic or pterygoid implants for now. But very soon you'll be able to do the moderately atrophic maxilla with transnasal and transpalatal implants. So you can do these implants in combination with GBR without a problem. So I think that's really not an issue. As far as the shining goes, I know Dr. Ryan Dunlop has been using the shining. I'll have to ask him. I don't know if he's used it with the TRI implants, but I would imagine that they're going to be making a scan body or flag for every implant platform out there.
We have another question. This is probably for you, Dr. Broumand. I see you use a few different photogrammetry systems. Which do you prefer and why?
That's a good question. So in my practice, I started using the PIC Dental. It was the first one out there, and I really love the PIC Dental. I made the mistake of letting someone borrow my PIC Dental and they broke it. So then at that point, I had to get another form of photogrammetry. So then I got the iCam, and the iCam ended up being so much better for my pterygoid implant.
Dr. Broman, are you still there? Not sure if we froze. Not sure if we froze here. I'm not sure if what happened here with Dr. Broman, but it looks like we lost him here and there was a freeze. But if anybody has any other questions, maybe I can take some that are not intended for an oral, at least for me, not being a surgeon. But if nobody else, let's see here. If he comes back on, I'd love to hear the rest of his answer. Yeah, absolutely. That was certainly a fantastic question. I can certainly talk a little bit about maybe the PIC and the iCam and the micromapper. At least from the PIC standpoint, we know the scan flags have been reduced in size, and that's certainly easier to work with patients. Obviously,
Chris, I'm back. Can you hear me?
yep. Here we
Yeah.
go. You're back.
Yeah, I don't know what happened. I'm back. Yeah, so really, in essence, it's whatever works better in your hands. So I have all three of them, and I alternate using them every single time we do a full arch case. What's like I said, if I'm doing a case and I'm going to require it to be guided as well, we have the NaviDent from Claronav. So what's great about the NaviDent, it's got a micron mapper, and it's got the guided XNav all together in one. So that's what's been great about it. So in one room I have the NaviDent with Claronav, and the other room I have the PIC, and in the other room I have the iCam. So it's what room we're doing surgery in, because I try not to have my photogrammetry move from room to room. I don't like that anymore, because for me it was a costly mistake one time. So some of my staff prefer the PIC, some prefer the iCam, some prefer the NaviDent. Personally, they all three of them work well in my hand. So it's whatever works best for you and works best with your implant platform. You have to remember, early on, PIC was the only one that you could use to implant or to multi-unit abutment. But now with iCam, you can do that as well. So you have to make sure that it serves your purposes the best. It's kind of like an implant system, right? What's the best implant for full arch? It's whatever works best for you. But they're all sturdy. So I love all three of them. They're fantastic.
Yeah, good. Any other questions? Well, we certainly, if there's no more questions, we appreciate everybody being a part of tonight's webinar with TRI and the one and only Dr. Vishy Broumand from Phoenix, Arizona. I think everybody saw my contact information. We're excited to get you set up on our TRI Matrix implant system. Certainly, if you need clinical support, like I mentioned, we have doctors on staff that can help your digital workflow and help with the Matrix implant. And we look forward to working with you. And thank you very much again for attending tonight's webinar.